Good afternoon. I have been standing here patiently for about 3 minutes waiting for the teapot to empty. And I think it's empty now, is it? In any event, we had a very, very difficult, hard-working morning, but I think it was a very useful morning. And I think the discussion on the submissions was particularly useful. And I also think the contributions we got in relation to how abortion operates outside Ireland was very useful. We had very good, instructive talks from the speakers, and I think it was very useful, although it required a lot of concentration, and an awful lot of it was very, very difficult to assimilate, but I think it was really useful. I think the afternoon, in truth, is going to be equally difficult, because we have a very difficult topic again, the topic of rape, and we're dividing it into 2 sessions, and the first session will deal with medical care path issues, and the second session will deal with legal issues. So we're starting with the first session, and our first speaker will be Dr. Maeve Eogan from the Sexual Assault Unit in the Rotunda Hospital, and then she'll be followed by Nolene Blackwell from the Dublin Rape Crisis Centre. So I think we might as well start straight away, and I'll call on Dr. Eogan to take the stand.
Many thanks, Chairperson, ladies and gentlemen of the Assembly and observers. So I have been asked to speak to you about pregnancy in the context of sexual violence from the perspective of the sexual assault treatment units. Obviously, I have never met any of you before. I don't know what your own personal past histories are, and sometimes some of the things that are identified in a presentation such as this can bring up issues that patients may have, or people may have had themselves in the past. And obviously there are a whole number of supports in terms of telephone counselling and person-to-person support provided by the rape crisis networks around the country. So if anything that I say upsets anybody, please ensure that you get the appropriate supports that you may require. I am an obstetrician and gynaecologist in the Rotunda Hospital, and in addition I'm the Medical Director of the Sexual Assault Treatment Unit in the Rotunda and the National Sexual Assault Treatment Unit Services. I am aware that as a group you like to have case reports and case presentations. Speaking to my colleagues in the Sexual Assault Services and also thinking about it myself, I have chosen not to give you case presentations while they would be anonymised and anonymous to all of us. A survivor of sexual violence may recognise themselves within that. So I've chosen not to actually give you case reports, but more to give you a framework of the services that exist, the supports that we can provide, and pregnancy in the context of sexual violence. So what we know is that there is no country and no culture that's immune to sexual violence, and furthermore there is no typical victim, there are no typical scenarios. We know in Ireland that the data is such that 6% of adult women at least have been raped as adults, with an additional 13% experiencing some form of contact sexual abuse. So really sexual violence is far more prevalent than we would probably individually think. The problem is that many, many people who have survived sexual violence never disclose it to anybody and carry that with them. And that is one of the challenges in terms of preventing pregnancy in the context of sexual crime. Why should people be helped and supported to disclose? Well, this enables them to access care. It enables them to have their physical and their psychological needs met. It facilitates them to access emergency contraception and to access prophylaxis or preventative treatment for infectious diseases. From the point of view of the criminal justice system, disclosure and engagement with An Garda Síochána allows an investigation to commence, and ultimately all of these pathways allow a patient's recovery to begin. These are the services for adults in terms of sexual assault treatment units that have been in existence in this country since 2009. The adult services, which I oversee, they accommodate men and women over the age of 14 years. There are some pockets of excellent care for children, for people younger than the age of 14 years in this country, but the services for children, I would have to say, are less standardised and less universally accessible. The services for adults include the SATU at the Rotunda, which has been in existence for over 30 years. There are newer services in Mullingar and in Galway that have been in existence since 2009. And in addition, there are sexual assault treatment units in Waterford, Cork and Letterkenny. And the aim is that nobody in this country is more than 3 hours from their nearest sexual assault treatment unit, so they can access care, responsive care, when it's required. Forensic examiners provide care with assisting nurses. The forensic examiners may be specially trained doctors or specially trained nurses. We have administrative support in each of the units, and we have links with the local rape crisis centres. In terms of attendances, all this information is within the documentation you have. Since 2009, when we've collated national figures, we've had pretty much between about 650 and 750 men and women presenting to the sexual assault treatment unit services each year. This is only the tip of the iceberg in terms of sexual crime. All the studies that are done nationally and internationally show that very many people don't disclose, so therefore don't seek care. And one of the aims of the sexual assault services is that we tell people about the services that exist. So if somebody is a victim of sexual crime, that they know that they can get care and attention and support. With this in mind, the vast majority of our patients come to us from An Garda Síochána. Probably about 8 out of 10 of all the patients who come to us come via An Garda Síochána, and they have reported an incident of sexual crime. But people come through a variety of other routes. They may present to the hospital emergency room, they may go to their GP, they may look it up on Google and find out that there's a sexual assault treatment unit at the Rotunda, Letterkenny, and go along to the unit themselves. Or indeed, they may contact the Rape Crisis Centre, either personally or through the phone support system. When somebody comes to a sexual assault unit, their physical and psychological needs are an absolute priority. So regardless of what statement needs to be taken, or what scenes of crime stuff needs to be done, or what's required in terms of detection of the crime, the physical and psychological needs are an absolute priority. The patient has 3 options, and we discuss all these with the patient prior to them deciding which route down which they're going to go. The majority of our patients, as I say, come with An Garda Síochána and have a forensic examination. They report the incident to the guards. They receive, when they come, comprehensive medical care, which would include emergency contraception and preventative treatment for infectious diseases. They have psychological support, and they receive forensic care. Their injuries, if they're present, are documented and treated, and the relevant forensic samples are taken, which help the guards detect the crime. Some people decide that they don't want to engage with An Garda Síochána, and if somebody is an adult and is over the age of 18 years, they can choose just to have a health check and care. In this context, they don't disclose to the guards. They receive a health check and medical care, which will also include emergency contraception. They're linked with rape crisis. And if they choose this option, I suppose the proviso is if they choose this and they subsequently change their mind and report the incident to An Garda Síochána, the opportunity to take forensic samples may be lost, and therefore forensic samples, so various swabs and samples that may be relevant to detecting the crime may have been lost, because DNA evidence does deteriorate quickly, and in simple terms, after 7 days there isn't any DNA evidence, and indeed the sooner the better we take DNA evidence if we need it. So if a patient is wondering whether or not he or she will report to the guards or won't, we would often say, go report to the guards. Ultimately, they may decide that they don't want to proceed with giving a statement, but at least if the forensic samples are taken, they have that opportunity to have those evaluated. The third option, and this is only available in the last year, is really when somebody is very ambivalent as to whether they wish to report the incident to An Garda Síochána. And in this setting, they can come to a sexual assault unit. We can take the relevant forensic samples and we can store them for up to a year. And that gives the patient the opportunity to consider, to discuss, to receive support, to talk to Rape Crisis, and to decide then in the fullness of time, up to a year, whether or not they wish to report to the guards. And if they do, then the crime can be detected. Option 2 and Option 3 are only available to those over the age of 18 years, and that is because of Children First guidance and the Withholding of Information Act. So those options are only available to adults over the age of 18 years. So regardless of which of those 3 options a patient has chosen, you can see by the detail I've given you that each of them will be offered emergency contraception. The rape-related pregnancy rate is unknown for an individual, but on a population basis, all the studies that have been done would extrapolate the rate to be about 5%. So about 1 in 20 people who are raped will become pregnant as a result of that. However, an individual's pregnancy risk is influenced by where they were in the menstrual cycle when that rape occurred, and indeed by other variables. So, if they have a medical condition, which means they're not going to get pregnant, they obviously are not going to get pregnant as a result of rape either. If somebody has the time that they're most likely to get pregnant is 1 or 2 days before ovulation, and that is the time in the month where a woman is most fertile. But obviously, depending on where they are in their menstrual cycle, their individual risk of becoming pregnant as a result of an incident of sexual intercourse may be a lot less than that. Emergency contraception, however, is very effective. It's successful in preventing pregnancy in the majority of patients, as long as it's provided within the appropriate time frame. The appropriate time frame is as soon as possible. And in this country now, people can access emergency contraception over the counter. And the reason for that was that people didn't have to wait to make an appointment with a GP or with a family planning clinic, that they could walk into a pharmacy and receive emergency contraception. Within the Sexual Assault Treatment Unit, we provide that, and we provide emergency contraception as soon as possible. So when the patient arrives, they will be offered it. In general, it's hormonal or medical emergency contraception that is provided. There are 2 main types we use, levonorgestrel and ulipristal acetate. Ulipristal acetate is more recently available to us and is used more frequently now because it seems to be much more effective. So that's the middle one on that slide there. It is effective up to 120 hours after an episode of intercourse, but it is more effective the sooner it's given, then the better. And therefore, because we give emergency contraception to all the patients who attend us, there are few pregnancies that result in women who attend the Sexual Assault Treatment Unit. However, I must give a bit of a proviso, because we see our patients at the Sexual Assault Treatment Unit at time 0, at the time the incident happened. We also offer them follow-up at 1 month, at 3 months and at 6 months. But about a third of our patients don't return for this follow-up. So while I'm standing here and relatively confidently saying that many women don't get pregnant after being at the Sexual Assault Treatment Unit, I would have to say that we don't see all our patients back, so I cannot be absolutely conclusive about that. Women do become pregnant after sexual crime, either because they didn't receive emergency contraception, so they never told anybody about it, or because the emergency contraception failed. However, what international studies have shown, women who do become pregnant after sexual crime are more likely to present later on in pregnancy, either because they didn't know they were pregnant, or because they just didn't want to admit that they were pregnant. So that does of itself limit patients' options if they do become pregnant after an incident of rape. This data I have taken with permission from the Rape Crisis Network. This is their 2015 data, and Nolene may well represent some of this information as well. This is within their submission to the Citizens' Assembly. They concluded that in 2015, of the people who contacted them, 5% became pregnant as a result of rape. Now, the people who contact the Rape Crisis Network are slightly different to the people. Some of them are the same people, but slightly different from the people who come to sexual assault treatment units. We see patients in sexual assault treatment units in the main acutely after an incident of sexual violence, whereas those who contact the Rape Crisis Network, it may be 25 years since they had their incident of sexual crime. It may be, for those who disclose child sexual abuse, I think the average is about 25 years before they contact the Rape Crisis Network, whereas with those who experience it in adulthood, it may be up to 5 or 6 years. So obviously these are a different population from those who attend the sexual assault unit. But within 2015 data, there were 46 girls and women who attended a rape crisis centre or contacted the phone line and were pregnant as a result of rape. So although it says in 2015, the rapes did not all occur within 2015. The majority of these survivors went on to give birth and parent. That was enumerated as 37%. 24% had their pregnancies terminated, and 11% of survivors who became pregnant had their child placed for adoption or fostering, and 28% of these had an adverse obstetric outcome in terms of miscarriage or stillbirth. So people do become pregnant as a result of rape, and obviously the decisions they make in that context may be varied, as that pie chart shows. What we would have to say in this country is people can only access pregnancy, or can only access termination of pregnancy following rape if there is a substantial risk to their life, which would include suicide. And as under disclosure of sexual violence is common, it is very likely that women who become pregnant as a result of rape in this country are represented in the population of patients who were spoken about this morning who travel for termination of pregnancy in another jurisdiction. So just to conclude, patient-focused services for women who've experienced sexual crime mean that pregnancies as a result of rape are infrequently encountered in those who attend the sexual assault treatment unit services. It doesn't mean it doesn't happen, but it is infrequently encountered because emergency contraception is so very effective. It is therefore imperative that people are encouraged and enabled to disclose sexual violence in the acute sense, so as soon as possible, in order that they can receive appropriate care to limit their short and long-term physical and psychological effects, and obviously those physical effects would include pregnancy. Thank you very much.